Council, Councillor Buggoth is proposed as the new chair of the Health and Wellbeing Board. Could all voting members of the board please confirm by raising one hand if they agree to the appointment of Councillor Buggoth as chair? Yeah, that's unanimous. That's a unanimous vote, so I would now like to welcome Councillor Buggoth to come and chair the remainder of the meeting. Thank you.
Good afternoon and welcome to this meeting of the Health and Wellbeing Board. I would like to inform those present at this meeting that this meeting is being webcast live and will be capable of repeated viewing. It may be worth explaining that voting members, including health partners, are in attendance in the chamber to take part in the debate and to make decisions. Some officers and partners will be joining the meeting via Microsoft Teams. Are there any members in attendance as substitute today?
Substituting for Hannah Yalden from East Sussex Fire and Rescue Service.
Do any members wish to declare any interest in relation to any matters included on the agenda? We have no part 2 item today, so the press and public won't be excluded. Does the board agree to approve the minutes of the meeting on the 11th February 2025 as correct record? Firstly, I'm sure that all board members would like to join me in thanking Councillor Bruno for his work in chairing the board. It's exciting to be asked to be the chair of the Health and Wellbeing Board. I'm looking forward to getting to know my fellow board members over the coming weeks and months. Like everyone on the board, I'm committed to reducing the health inequalities that exist in our city. It's only by partners working closely together that we are going to tackle the problem we have. I'm particularly interested in 2 aspects of health and care improvements. Firstly, what we can do as a system to move from a model that focuses on treating people in crisis to one that intervenes earlier to prevent ill health. And secondly, how partners can work together to support independence, giving people the help they need to live good quality independent lives. It's good to see that the reports we are looking at today have a real focus on prevention and on supporting independence. And it will be really interesting for me to find out more about how the system is working to deliver these aims. The Democratic Service Officer will now undertake a call over items 28 to 30 And I ask that members indicate those items they wish reserved for discussion by calling them as appropriate.
Thank you, Chair. So 3 items today. Item 28, the Shared Delivery Plan Annual Update. Item 29, Suicide Prevention in Brighton and Hove. And item 30, the Better Care Fund. I can confirm that all items have been called. Thank you.
We have one public question from Mr. Adrian Hart. Mr. Hart, would you like to ask your question?
Thank you. For several years, a very serious schools safeguarding matter raised by parents has been rebuffed by the council. I refer to my question at full council on the 20th of July 2023, but also to the parents trying desperately to alert this administration to the plight of their children who are typically autistic, female, and same-sex attracted. You will be aware of the case brought by a Brighton parent against NHS Sussex, ICB, NHS England, and Brighton Wellbeing, which was heard in London's High Court yesterday. These pupils represent a subset of the group who have been affirmed at school. Henceforth, the child identifies as the opposite sex and the school participates with the process known as social transition. The logical next step for these pupils has been to seek puberty blockers and or proceed along a medical pathway to transition. So this is my question. While it has been argued that the latest version of the toolkit guidance adheres to legal safeguarding requirements, will the chair or anyone here meet with PSHE Brighton parents and listen to their truly shocking accounts? Thank you.
Thank you for your question. As you'll be aware, it is not appropriate for the board to consider or comment upon individual cases. Equally, it is not a function of the board to examine your perception of decisions made by medical practitioners or schools. The role of the chair is to chair meetings where decisions are made by board members. It does not extend, nor would it be within the proper functions of the role of the chair to meet with individuals outside the board meetings to discuss issues specific to them. Any individual wishing to raise an issue or complaint can utilize the council's complaints processes, NHS Sussex ICB complaints process, or Health and Social Care Ombudsman. Do you have a supplementary question?
That was disgraceful. Yes, I do. My follow-up question is ICAMS, the ICAMS service, Infant, Child and Adolescent Mental Health Service, children's social work services and local NHS GPs funded by the Sussex ICB are each contributing to a pipeline of children being transitioned in school and social services settings and in social services settings and medicalised by the NHS locally with irreversible consequences for the 16-year-olds affected. I would hope that this board agrees with the review conducted by Baroness Cass and the position of both the government and His Majesty's opposition. However, the practices you are overseeing in the city, you, the board, are entirely outside of Cass and government policy. The board will be aware of cases on these matters heard in court this week. The families instructing these cases are not alone. PSHE Brighton are formed of many families just like them. Does the board disagree with Cass, and why does it refuse to meet PSHE Brighton families? Your answer just now notwithstanding.
We'll answer. We'll give you a written answer after the meeting.
Excuse me?
We'll provide a written answer after the meeting.
Does the board disagree with Cass? And why won't it meet? Why won't it follow a safeguarding? Why won't this council follow a safeguarding first approach? Simple question.
Like I said, you'll get the answer written after the meeting. Thank you.
Seriously?
We have a question from Councillor Bruno de Oliveira. Bruno, would you like to ask your question?
Thank you, Chair. Hello, members. Chair, given the government's planned tightening of the personal dependence payment, PIP, eligibility, the halving of the health-related universal credit for new claimants, and the withdrawal of the incapacity support for under 22s, could you explain to our residents how these austerity-driven reforms will affect the lived realities of disabled and chronically ill residents in deprived areas of Brighton Hove, many of whom already experience system exclusion from the labour market?
Thank you for your question. The government's recently announced welfare reforms are wide-ranging, and while they may have a positive impact for some people, I recognize that there are bound to be city residents who are going to be affected negatively. The council is committed to doing all it can to support local people who are struggling financially. Our poverty reduction work includes working closely with partners to understand the local data on poverty, encouraging people to take up all the benefits they're entitled to, signposting to support services, whether run by the council or our community and voluntary sector partners, and providing direct support through our local fairness fund.
Follow-up question, Chair.
No, there isn't a supplementary for member questions.
I would like to invite Steve Hook to introduce the report. Also presenting will be Imogen Blood of Imogen Blood Associates, who have been undertaking an external evaluation of the multiple compound needs program. Charles Walker, our program director, and they will be joined by members of Common Ambition, the lived experience group supporting the multiple compound needs program, including Nikki Piper, who coordinates the group. Finally, Tanya Brown-Griffith from NHS Sussex Integrated Care Board will set out to the board the proposed shared delivery plan objective for 2025-26, which we are asking the board to approve.
Thank you, Chair. Good afternoon, board members. I'm Steve Hook. I'm the Director of Adult Social Care, and I'd like to introduce the report concerning our shared delivery plan. The report sets out for the Health and Wellbeing Board our review of our performance against 24-25 shared delivery objectives, with a focus around our place-based partnership, and it sets out our objectives for 2025-26. And just to note, the board are requested to note the performance around our shared delivery plan for 24-25 and approve our draft shared delivery plan objectives for 25-26. So by way of summary, the Sussex Integrated Care Strategy, which is known as Improving Lives Together, was launched in 2022 as part of the new Sussex Integrated Care Partnership arrangements. So each Integrated Care Partnership, of which we are part of the Sussex Integrated Care Partnership, is required to agree a strategy and a forward plan, which is known as the Shared Delivery Plan. Our Sussex Integrated Care Strategy and Shared Delivery Plan include some of the key local priorities as set out by our 3 places across Sussex, that is namely East Sussex, Brighton and Hove, and West Sussex by our health and care partnerships. And in line with the responsibilities of this board, we're focusing today on our objectives for last year and our delivery and the objectives for next year. So we've been successful over the past year as a partnership in delivering on our agreed shared delivery plan priorities. We have established our local infrastructure that will support the development of our integrated community teams. Sussex now has 13 integrated teams across the 3 places, and Brighton and Hove operates as a single integrated team footprint, and we're currently determining how we will deliver and operate within that. We plan to deliver within 3 footprints within the city. We have moved from a multiple compound needs pilot programme known as Changing Futures to partners agreeing a new multiple compound needs integrated community team model, and I will introduce Chaz in a moment to take that forward. Bearing in mind, we have members here today from Sussex Partnership Foundation Trust around our mental health. We are also aligning our 3 neighbourhood mental health teams with our local integrated care team partnerships. Through our new partnerships, we've continued to deliver our population health, our health inequality, and our integrated community team test of change programme. That's a summary of our deliverables over the last year. And I'm now going to hand over to Chaz, who's going to introduce our colleagues around our evaluation. Thank you, Chair.
Thanks, Steve. So we thought we'd spotlight on our multiple compound needs programme, just to give a bit more detail to the board. It's our community frontrunner programme for the integrated care strategy, so it's a key responsibility for this board. It also informs the development of the wider integrated care strategy. So we've got some guests joining us today, so we thought you'd find it really helpful to hear from Common Ambition Lived Experience Group, who've been supporting the programme. So they'll talk a bit about their work and how they've supported the programme through a lived experience lens, as that's a key part of the methodology for the integrated care strategy. And then one of our shared delivery plan objectives for this year was to get an independent evaluation of the pilot programme. So Imogen Bloods joined us online today to present to you on the findings from that evaluation report. So if I could welcome Common Ambition to join. I think they're going to sort of come up one by one and just present a little bit about their work and how lived experience is informing the development of the programme. So.
Hi everyone, my name's Nikki Menon. I'm one of the participation leads for the Common Ambition project. Nikki Piper sends her apologies, she's not very well today. So I just wanted to start with sharing our safety and wellbeing kind of procedure that we've put together over the last 4 years. We've been to quite a few meetings and events over the last 4 years together. We've experienced good and bad practice at those events and meetings. So I just wanted to share with you what we've put together to try and make our spaces safe. So please make sure that you're using language that everyone can understand. If you do need to use technical words or an acronym, please explain what it means. Please refrain from asking personal questions. There may be some difficult or upsetting content discussed. We as a group always make it clear that people can feel safe to leave the room if they need to. Please actively listen, don't speak over others, and don't interrupt presentations. And please wait to the end to ask questions. There will be time for questions today, but please, we really ask that all the questions are focused on the work and what we've done and not on any personal experiences. If we feel uncomfortable, we may not answer your question. Thank you. So I'm going to be joined by some members of the group that are going to tell you a bit more about what we've been up to. So we're going to be doing a bit of a cycle. Should I get another chair here?
Hi everyone, we are Brighton and Hove Common Ambitions. Our aim is to improve support services in Brighton and Hove through co-production and advocating for lived experience voice to be central to service and system change. We bring together people with lived experience of multiple compound needs, services and commissioners through co-production to improve outcomes for people experiencing multiple and compound needs.
Common Ambition has been running since 2021, and in that time we have created voice for people with experience of homelessness, developed a work and learning pathway for members. We have had members move on to work, volunteering and research roles, developed a unique trauma-informed approach. This means we can work safely and effectively, mapped and identified barriers and challenges within the system and pathways, co-produced processes, guidance, communications and lived experience-led events to share our learning, carried out 18 co-production design sprints, including looking at co-designing improvements within services and the system, including developing medical student training, mapping the housing pathway, service improvement consultations, and co-producing a comic to raise awareness for the challenges people experiencing homelessness face. And in the last 2 years, we've developed into a bigger program of co-production work in the multiple compound needs sector, including the drug and alcohol lived experience program.
In 2021, we mapped the system in Brighton and Hove and identified the challenges and barriers within it. There were over 100 challenges, which we themed into 12 challenge areas that you can see here. The challenge areas that we think are addressed through the work of Changing Futures multidisciplinary team and wanted to highlight today are: often people accessing homeless services find the staff are not holistically trained in all areas, e.g. mental health, substance use, dual diagnosis and physical health. This leads to them not being treated holistically. There is a lack of trust in the healthcare service. This comes from misdiagnosis and a lack of joined up services. Substance use is a barrier to accessing services because of the policies preventing access and the lack of awareness and training. There is no continuality of care along pathways, particularly at the end of housing pathways to finish rehab or leaving prison. And communication and care between services can be disjointed. Databases do not join up, and this often results in people having to repeat their story.
Good afternoon. The group carried out our initial consultation meetings with CHAS worker, which enabled us to understand how MCN transformation program will work, consult on the MCN transformation program aims and objectives, feed into the development of the work streams. The group then had the opportunity to meet the Changing Futures multidisciplinary team leads. This helps to understand who is in the team, how it will work, and feedback ideas that we had for the team. From now on, we will refer to this team as the MDT.
In parallel to the development of the MCN transformation program and Changing Futures MDT, the Common Ambition Group were co-designing a lived experience specification for homeless help in the city. We see a hub as a community space where all services work together under one roof, an accessible learning and information sharing space where people who use services are listened to and are engaged fully in the development and delivery of its work. Our idea was for the hub to include an information hub, including information on the city's services and access to the internet and phone, a services hub, frontline services including healthcare under one roof, a community hub, a space for people to connect, and a learning hub, a training and research space. These two work streams are now coming together, and we firmly believe that the MDT is the first step in delivering a hub approach in the city. You can find the full specification of this on our website. Thank you.
There is a timeline of our work evaluating the MDT. In May 2024, Jez Walker came back to the group to develop the idea of a peer evaluation to feed into the main evaluation. In July, we had a collaborative session with the MDT peer support team to co-design data collection processes. In August, we had a collaborative session with IBA's Paul to understand evaluation methods and co-design our analysis approach. We then carried out 6 data analysis sessions between September and November last year. It was really interesting to put ourselves in someone else's shoes, and we really enjoyed the process. In January this year, we had a wrap-up session which included feeding our into our wider evaluation.
The process we used to analyse the stories collected by the peer support was most significant change, which was suggested by IBA, Imogen Blood Associates. It is a trauma-informed approach to interviewing clients with no need to share past experiences. Common Ambition were able to co-design the approach to the methodology and work with the peer support team to co-design a data collection process. Common Ambition analysed the stories collected, pulled out key themes and recommendations based on the knowledge of the system and our lived experience. The co-production questions for clients included: what was the effect, good or bad, big or small, for you as a result of working with Changing Futures? And to give an example of small effects so that people would know what the changes were and how they were significant. Which of these effects mattered the most to you? And would you like to tell us why? How did it feel before, and how does it feel now? What was it about Changing Futures offer that helped to make the difference? There was also the optional questions that was there anything that could have been done differently? We really enjoyed working with the peer support team and feel that we've learned a lot from the process. You can really see the value of lived experience involvement.
Our key learnings and recommendations are that this way of working works and is part of the solution to many of the challenges we identified in 2021. Time to build relationships and trust and consistency throughout our key. Trauma-informed working is vital. This team is the first step to the ICT integrated care team and a hub approach. Short-term funding is a hindrance. More time is needed to see the true impact of these initiatives. We need to put time and care into designing how people move on from this service. Let's try to stay away from acronyms where we can. One of the things we really wanted to highlight is how invaluable the peer support team is. We learned so much from this process. It has upskilled us as evaluators. Lived experience evaluations bring new ideas and ways of analysis to the table. And last but definitely not least, co-production and lived experience must be central to the development of the ICT. Our unique perspective will be key in developing this. Thank you.
I've had the privilege of working with Common Ambition Steering Group for the last 2 years, and I hope that gave you a flavour of the amount of work they put in voluntarily of their own time to support the development of the programme. So it's probably nice to have the chance to say publicly to thank them for all the work that they've done, and it's been invaluable in terms of getting the programme to where it is now. So just to quickly... So they talked a lot about peer support. So just to explain a tiny bit more about, within the multidisciplinary team that we've been testing, we've actually had people with lived experience employed in the service as peer support workers to help build trust with the clients that we work with. And so when they talked about the peer support, that's what, yeah, and I think Imogen, who's on the screen, is going to talk to us in a second, will actually expand a little bit more around the real benefits of that innovative approach. So yeah, Imogen's not based in Brighton, so she's joining us online today. And Imogen joined us just over a year ago as our external evaluation partner, and has been working closely with myself, the MDT, Common Ambition, and a number of our other partners to evaluate the programme. And so we thought it'd be really helpful for this board just to hear a little bit around the key findings and recommendations from the evaluation. So hand over to Imogen.
Thank you very much, Chaz. And yeah, I'd just really like to echo the thanks to Common Ambition. It's been a real joy to work with you, and thank you so much for your presentation. So yeah, I'm just going to talk you through some of the kind of, the key, give you a quick overview of the independent evaluation that we've been carrying out over the last year or so, just to I suppose kind of assure you of the breadth and the depth of the approach we've taken. You've obviously just heard from Common Ambition, our lived experience partner, about the process which they have been leading on, supported by the peer support team to collect stories of change. And it's important to just kind of add that actually 4 of the stories of change that they collected were from clients of the service, but they also collected stories from 7 workers within the multidisciplinary team. So we had a really nice kind of mix of stories, understanding the kind of balance, really nice balance, looking at both aspects of experience. And then the rest of the team, we conducted a number of staff interviews and observations of the team in action. We worked really closely with the project and also with the multiple compound needs steering group to develop a theory of change. I'll share that with you in a moment. We looked at lots of documents and case studies. We analysed the administrative and monitoring data, and we held group or individual interviews with 28 other professionals outside of the MDT, sort of broadly exploring themes around co-occurring needs, around hospital discharge, around the functioning of the MARAC, the multi-agency risk assessment group, focusing on domestic abuse. Sorry, I'm just trying to model the spelling out of acronyms, and also around sort of safeguarding and housing. So that's the kind of breadth of our activities. And I just wanted to start off by pulling out a few kind of key points of learning, I suppose, from the process, the implementation aspect of our evaluation. And I feel these are really important for moving forwards into the integrated care team, the implementation of that. there was a really clear theme, and this really came out from Common Ambition's analysis about just how important it was for the members of that multidisciplinary team to really learn from each other's diverse professional and lived experience. We've touched on the role of those peer support workers, and that how necessary that is if we're going to develop the kind of holistic best practice with people with multiple and compound needs that Common Ambition have just highlighted is so important. I really like this quote that came out of one of the stories. The team has multiple domains of knowledge and expertise. You just can't hold all of that in one person. The team has to mirror the complexity, and the MDT has helped us to make sense of that complexity. There's another really clear finding about just how quickly and easily workers can resolve issues if they're in the same room, and it's been quite important that the staff team has kind of committed to only being able to work from home on a maximum of 1 day a week. There's just something there about just being able to check in with each other and sort things out rather than waiting for emails and trying to get through to each other on the phone. It's been really evident that very strong management support, lots of investment in reflective supervision and in staff and peer support, learning and development have been really key enablers. It's really important not to underestimate how much we need to invest in those things if we're going to do this kind of work sustainably and well. And I think I'm really struck by my work up and down the country in this area about the location and the leadership from adult social care in relation to hosting this multidisciplinary team. I think there's lots of learning there about how that's enabled this work to be held within a statutory safeguarding and care act framework and what that brings to the work. But it's really important to flag as a word of caution that it has taken quite a long time to sort of bed in the different roles and how the kind of line management arrangements and support work within the host agencies. And those challenges, which I know Common Ambition have already touched on around working, things getting recorded on different databases, has been a real challenge for many of the staff team as well, trying to sort of record across multiple systems. And that's an area which, we need to kind of continue to develop around, challenging though it is. So this is the kind of the overview of our theory of change, just to say that we adopted the kind of the different layers of the theory of change that had been adopted by the National Changing Futures Evaluation. And we really like the fact that that looked at the impacts that had happened at both an individual, a service and a system level. So we've kind of drawn that out throughout our evaluation. And through the initial phases of our observations and our data review, we highlighted the following half a dozen kind of key areas where we could see impact. We've already touched on trust and engagement and just how critical that is for this group of people, and what a key enabler that is to people being able to then go on to engage directly, particularly with health services, as we've already flagged. Safety, there were lots of examples of people's safety being increased, but also some really key learning about holding the risks for these individuals in a multi-agency safeguarding structure. I'm going to talk more about health, mental health and housing, but I just wanted to flag up the importance of the work of the MDT in relation to meeting basic needs. Many of the people that the service is working with are effectively destitute, and the importance of the fact that there is a flexible personalisation budget, and that workers have been able to both refer into lots of food and other kind of basic support agencies within Brighton and Hove, but also that they've been able to access care and support via Care Act assessments has been really key. And just finally to mention on this slide the point about self-connection and recovery, really encouraging to see a significant number of people within the MDT who've been working really kind of at quite a sort of deep interactive level with the peer support team in relation to their own recovery from drug and alcohol use, and just wanted to flag how important the peer support element has been in relation to that. Really, people have responded really well to being able to work with people who really understand where they're coming from, and those peer support workers have played a really key role in helping people to link into the really rich recovery network and resources within the city. So I want to spend the rest of my presentation just really highlighting what I see as the key progress and also the key next steps, I think. And I want to map those against the key recommendations of the Joint Strategic Needs Assessment, JSNA, that was carried out on multiple and compound needs back in 2020 in Brighton and Hove. It was actually published in 2023. And of course, the Health and Wellbeing Board has oversight of those recommendations. So I thought it would be particularly useful just to flag where I think the kind of key learning and ongoing or outstanding areas are. So I'm just going to quickly whisk through a slide on each of these points that you can see in this circle. So firstly, I touched on the point about information sharing, trust and shared systems. This was a recommendation from the JSNA. And as I've already flagged, the MDT has really tested trying to work across those multiple systems. It's taken quite a lot of staff determination. And I think there's still a way to go on that. There are, of course, huge barriers around how we share information about individuals across agencies, but I think there are some important next steps around implementing Plexus Care Record. I think that would help us to share information across health, social care and housing, and certainly really early consideration of information governance within the integrated team is going to be really key. And, this is how we can achieve that vision of trying to make sure that people aren't repeating their stories and that we can work as holistically as possible across our service silos. We've talked already a lot today about the importance of lived experience in service design and delivery. I just also want to flag that the peer support team have also sort of begun to design a number of resources, and there's been a huge amount of learning in this pilot around how to really effectively support and manage a peer support team. Things that really require quite a lot of investment of time and money. And of course, you will already have seen in action Common Ambitions, evaluative skills and insights. So it'll be really important that we think about how we build in and properly resource both peer support in the ongoing design and delivery, and also Common Ambitions input from an evaluative and design point of view as we move forwards. We've touched on the importance of having that continuity of care, of having a care coordinator for multiple and compound needs. And of course, that was very much the purpose of the Changing Futures MDT, to sort of test out how that might work. And what's been found is that what works really well is to have a small, consistent team around each individual. It's known also as a team around me model. And as I've already touched on, having that hosted by adult social care, I think, is particularly key from a statutory point of view. And this kind of small team has the benefit of giving somebody a named contact, but it also makes it more sustainable for the workers. It's not just one care coordinator. There might be 2, 3 or 4 people with the right kind of skills, supporting each other, covering for each other, but providing that ongoing continuity. And I think that, the challenge moving forwards is to roll this model out now to more people. And I think the way to do that is going to be by trying to reduce duplication and combining resources as much as we can within the system, because this is a great model at the moment for 60 or so people, but we know there are so many other people with multiple compound needs in Brighton and Hove who need to also benefit from this. We've already touched on those barriers to people accessing accessing both mental health and substance use, but probably most pronounced accessing mental health care if they are already using substances. And this has been really highlighted as an ongoing challenge through the pilot. I think it's fair to say we've got a better understanding of what's needed. And there've been, both in terms of providing the support to the MDT team on the ground and, starting to get a sense of what a much more integrated way of working might be. But I think it's also true to say that there wasn't enough dedicated mental health resource within this pilot, and it'll be really important to ensure that access to psychology and psychiatry are built into the integrated team. It's not just about reducing those barriers, it's about us really rethinking how we work in a truly integrated way with people whose needs overlap both specialisms. Trauma-informed practice, there's been huge progress, I think, in really developing what a model of trauma-informed practice looks like, developing the kinds of resources around staff management, learning and development to support that sustainably. And it'll be really important that we build that training, learning, those resources into the integrated team. But it's also flagged, I think, the fact that there is evidence of a kind of ripple effect starting to happen out from the practice of this team, but there's obviously more ongoing work to do to make sure that this kind of trauma-informed way of working with this group of people is really consistent across hospital systems, across the multi-agency response to domestic abuse, across those wider social work teams. That's a bigger project of cultural and staff change. Suitable housing, care and support has come up, as you might expect, as a huge issue, and it's true to say certainly that the lack of suitable housing has limited the impact of this team, but there's also been some real progress made in building very positive partnerships with care and supported housing providers within the city to work together for this group of people. I think moving forwards now, we need to formalise some of those pathways. We need to look at whether and how we might scale up housing first in the city via the integrated team model, and we need to continue, and I know this is already starting to happen, to influence the homelessness strategy that's being developed at the moment, make sure that there's a really key kind of strand in there around multiple compound needs. The pilot has very much kind of confirmed the value of having specialist domestic abuse resource. There's a worker within the team who's a dedicated specialist worker around domestic abuse. And it's really confirmed how important that is. I think at the start there probably wasn't enough of that resource, and that's been expanded over the course of the pilot. And where people have been able to access gender-specific safe accommodation, that's been massively valued, but in many cases they haven't been able to. There isn't enough of that in the city. So it'll be really important moving forwards to kind of make sure that we're building that specialism in, and that we're continuing to develop those ongoing partnerships with specialist providers in the city to make sure that gender specific services can accommodate people with multiple compound needs. And just my final slide, addressing physical health needs. I know this is kind of very much the primary focus of the Health and Wellbeing Board, and I just wanted to share the probably obvious reflection, but nevertheless it's important to say it again, that the evaluation has very much confirmed the high levels of physical health needs that are evident in this caseload. It's really important that we think about how we address physical and mental health needs in the round for this group. The pilot has very much flagged the positive partnerships with primary care providers, which, as many of you will know, in the city, the primary care delivery with people experiencing homelessness is led by Arch. And also substance use services, Change to Grow Live, have been embedded within the multiple disciplinary team, and that's worked really well. But as you might expect, kind of consistent communication across hospital is much more challenging, much larger systems, and there's more work to be done there. So I think moving forwards, there's a need to further integrate, make sure that Arch is thoroughly embedded within the ICT approach. And you've already heard from Common Ambition about the Homeless Health Hub's vision. And I think whilst the Changing Futures team has worked, with its clients across into the hospital system, the pilot has very much flagged the fact that there is more widely a lack of multiple compound needs specialist social work expertise within the hospital system. So I think that's all I'm going to say for now, but happy to pick up any questions in a moment. Thank you.
Thanks, Imogen. So I'm very mindful that we're talking about a pilot and we're talking about evaluation. So I've just got a couple of slides just to say what the next steps are. So as a board, you're aware of how we're actually going to progress. So just bear with me while I just share my screen again. So evaluation that Imogen just presented to you was presented at the end of last year to we have a multiple compound needs partnership group, and we had an actual Multiple Compound Needs Summit, where actually in this room at the end of November, where all partners involved in delivering services to people with multiple compound needs in the city came together to look at the learning from the pilot and through the evaluation and to agree next steps. So it was a really positive day, and what everyone agreed was we need to progress, we need to move forward, we need to move from a pilot to a steady state position. So the Partnership Summit agreed that the city would benefit if we then took the learning from the pilot and build that around the new integrated community team model. Obviously in Brighton and Hove, as Steve explained, we've got 3 neighbourhood teams, but because we're 99% of people we're working with are homeless, it doesn't necessarily fit well into a single neighbourhood. So it was felt that actually for this targeted group, this is a community of identity that we need to work on a citywide basis. So multiple compound need, we agreed to form an integrated community team around multiple compound needs on a citywide basis. And that the focus of the team would be for people who are homeless with 3 or more multiple compound needs. So very much reflecting the work that Changing Futures did. All the multiple needs mapping we've done today show there's probably up to 1,000 people in the city who would have 3 or more multiple compound needs. So I know it's not very clear, it might be a bit clearer on the screen, but just in terms of the partners that we agreed would form that integrated community team. So we talked a bit about Arch and their role as our homeless healthcare primary care practice. Partners agreed that they would chair and lead the group from a primary care perspective. And then we're very fortunate in the city through our sort of community health trust, SCFT, they have a specialist health inclusion team. So they agreed that the health inclusion team should be part of the new MCN integrated community team. For mental health, we are also very fortunate we have a specialist homeless mental health team in the city. So SPFT agreed that that team should be part of the new MCN integrated community team. From the local authority side, we talked a lot about the importance of social care and care at work and safeguarding work. So that Changing Futures team and the social workers within it will be part of that alongside our sort of housing options and our Rust Sleeper. We also agreed that Common Ambition should be a partner, and so they're named as a partner in terms of being part of that integrated community team and part of the leadership work that integrated community team will do. So they're the partners in the sort of green dots on the outside. What's in the middle is where we recognise that we will always need that assertive outreach approach that was the best sort of inclusion health, where actually we need to go to those people in our city who need that support. They won't necessarily come to us. So we're maintaining that Changing Futures team. So we have the actual resource in the integrated community team to continue to do that multidisciplinary sort of proactive sort of care coordination. But we're going to add to that team with the recognition that within the local authorities sort of Rust Sleeper services, we have a navigator team that do a very similar role, and they can sometimes find themselves duplicating. So they're going to come together as a single assertive outreach support team for people with multiple compound needs in the city. So that's the partners. The partnership also agreed a set of principles. So that we talked a lot about the work being client-led, around shared accountability, around service continuity, so not one person passing over to another, but partners staying involved, and then around continuing to innovative practice like the peer support and the personalisation budget. So they were agreed as principles that we would want to underpin that new integrated community team. The teams started to meet. They got an action plan. Part of that action plan will be taking the recommendations from the evaluation report and actioning those recommendations. So that's sort of spotlighted the multiple compound needs program. Just to end the presentation, I think Tanya, you're going to come and join me and just talk a bit, because we've got a wider set. It's not just multiple compound needs, which is in our shared delivery plan. We've got a number of other priorities that Tanya's going to go through in terms of that we want you to support today.
Thanks, Chaz. I'm Tanya Brown-Griffith. I'm also a member, but I am from NHS Sussex, and I'm the Joint Commissioning Director for Brighton and Hove.
And having worked closely in the city for the last 10 months since starting in role, I must say that I've seen some really good collaborative pieces of work in the city. And therefore, in setting or shared deliver priorities for next year, what we didn't want to do was just to carry forward the objectives that we'd set in the previous year, but more so to learn from the evaluation, but also the lessons that we'd taken out of some of the pre-pilots, some of the test of change into setting the priorities for this coming year. And in doing that, what we did was we looked carefully at what we did last year. So we had 8 shared delivery priority areas we focused on, and each had 4 objectives. And we had spread ourselves really widely, trying to capture enough information on all of those objectives. And what we want to do for this year is to hone in and really focus on the areas that will make the biggest impact for population, particularly learning what we did from last year. So what we now have are 3 priority areas, as you can see on the screen. But within those priority areas, what we carefully looked at is the Health and Wellbeing Board's priorities, the local authority priorities, and the NHS, so the neighbourhood health guidelines and the planning guidelines that was recently released by NHS England. And what we also needed to take into consideration is where do we need to see the biggest impact, which is on avoiding admissions, unnecessary admissions to hospital, but keeping people in the communities provided for in the communities, and obviously supporting persons who do need to go into hospital for acute and critical care to come back into the community in a safe manner, but also feel supported by the services we have in the community. So as you can see, we've got those 3 priority areas, and within those 3 priority areas, we have several objectives that really focus on, 1, embedding frailty. And frailty isn't just tackling concerns for older persons. It's looking at those persons with multiple long-term conditions. And obviously, as we heard from our partners, heard from Chaz and Steve, the Multiple Compound Needs Programme in Brighton is one of the flagship programs, but we now need to embed that program. We now need to scale that program, and we now need to ensure that all of our provision, both health and social care, are aligned around the sort of small pilot that was tested over the last year. So as you can see there, what we want to do now is to embed, to widen, to scale, but to start to evaluate more robustly the impact that this had on some of our key priorities for our population, which is supporting people to live well at home where possible, and to improve the support services around the health and well-being offer. So as you can see, we went on to then to think about, so what else do we need to focus on? And that led to priority 2, which is prevention. If we are going to keep people in the community provided for, and obviously ensure that we prevent unnecessary admission to hospitals, we need to focus in Brighton and Hove, and CVD, cardiovascular disease, is a big area for us. And falls prevention is another big area for us. And obviously cancer, continuing to improve our care for, especially on persons who are looking at cancer, both from a screening perspective, but also from a follow-up point of view. And we also needed to ensure that we continue to address the inequalities that we had identified over the previous years. We then wanted to ensure that we reflect the Health and Wellbeing Board's particular target on children and young people, and therefore the focus on mental health and emotional well-being. And that was a specific focus for us, transitioning age from those young persons leaving school age into obviously adult services, both from a health but also a social care point of view. And we've had a lot of data, richness of data over the last year through the health counts data. And what we wanted to do was to now look at that fresh new data and start to work out the delivery of services over this year, particularly targeting on communities that we knew were not receiving optimal care. And that's from a health and also community social care provision. And then lastly, we wanted to continue the work we're doing around our neighbourhood care teams, so the integrated community teams as referenced to before. And we're building in some new pilots for this year, so things like the Women's Health Hub, That's been a model that's been pulled through nationally in terms of having a one-stop shop care for persons, women who have multiple needs. And instead of having women accessing 8 or so more services, trying to bring that into a community setting with those specialists in that community setting. That's part of delivery of our integrated community teams. We spoke earlier about the neighbourhood mental health teams. This year, we now want to ensure that those 2 teams, so integrated community teams and the neighbourhood mental health teams, are not seen as different teams. We want to ensure that they're integrated locally in the 3 neighbourhoods across Brighton and Hove. And we've begun some really good work to start to work that through. We also wanted to ensure that we target economic inactivity and, where possible, those persons who were either out of work or off ill from work, and ensuring that we're driving our economic activity within the city and ensuring the right services are supporting those individuals back into work. And so the Work Well programme is one of our areas that we'll be focusing over this year, particularly in the east area of the city. So I won't go on too much. I will just end with saying that this year, what we want to focus on is what we can evaluate, what we can obviously ensure improves access, but also better outcomes for people. Thank you.
Do you have any questions or comments? Yeah.
Thank you, Chair. I'm just blown away. This sounds absolutely fantastic. And, you know, when I'm hearing the words about holistic approaches and chance to build trust and relationships, and having listened to that lived experience, which is so valuable to provide this. So I'm just really, really pleased, and I think it's a massive step in the right direction. I'm a bit confused about the timelines. So where we've got the multiple compounding pilot that's just happened, does that now stop and then we start going somewhere? Are we on the journey already, or have we? Because it says in here when March 25. Oh yeah, I didn't read it right. Sorry. Yeah, so we're actually on that journey already, and it's all systems go from here. Yeah.
Yeah. So we on the back of the pilot, we're developing a bigger integrated community team, but within that integrated community team, the Changing Futures team, which I know, Councillor, I'm sure you came and met, didn't you? So they're being maintained, but being sort of within the wider integrated community team. So the work's going forward, not as a pilot, but as the way we want to provide services to people with multiple compound needs in the city. So.
Yes, well done. Thank you for all your work, and I look forward to hopefully hearing how it's progressing. Thank you.
Stephen.
Hello, yeah, my name's Stephen Lightfoot. I'm the chair of the NHS Sussex Integrated Care Board. First of all, can I just personally congratulate all of the individuals with lived experience that have given such a compelling presentation today. So thank you very much. I really do appreciate that. I've got a comment and a question, if that's okay. In terms of the longer term future, I absolutely agree with the direction, but I think we also just need to be aware that the government on the 13th of March announced that NHS England was going to be abolished, and all of the integrated care boards, including NHS Sussex, had to reduce its running and programme costs by 50%. We have to submit a plan to the remaining transition team of NHS England by May of this year, and we have to have removed the cost by the end of this calendar year. So although the priorities I am 100% supportive of, in terms of the NHS Sussex contribution to that, at this moment, I don't know how much we'll be able to contribute, because we've had no real further direction from the government in terms of how we need to rearrange our roles and responsibilities. And so that probably means that we won't receive details of our roles and responsibilities until the end of April to get what's called a model ICB in terms of what our responsibilities will be. And then we'll be given 1 month to actually redesign our organisation, and then probably about 3 to 6 months to implement any changes. So I just wanted to make that completely visible to everybody. But in terms of our ambition to support this agenda, we will do as much as we can with the more limited resources that we'll have in the future. So I just wanted to make that one clear. I think there's been so much learning. So that was my comment. My question, if I may, is there's been so much learning from this pilot project. I'm wondering if we can use some of that experience with other population groups. And I'm thinking of the frail elderly in particular, in terms of then how we can actually then really drive forward the prevention agenda on cardiovascular disease and also respiratory disease and also on cancer. So I'm just wondering, can we use some of the learnings from this programme onto other population groups?
The answer would be absolutely. I mean, Chaz, you might have some examples, but Stephen, just to assure, we are discussing the multiple components program in all of the different ICTs, and we've got 2 test of change programs on frailty, one in the west of the city and one in the east of the city, that we're beginning to show good progress, and some of the learning, particularly from the lived by experience team and the peer support, are models that we're beginning to think through for the frail, but also the sort of frail elderly model as well, not just in terms of frailty as a sort of a definition. Charles?
I think some of the key learning is around actually delivering an MDT. Yeah. So there was some really good learning about how you support staff and how the environment. I think there's real learning about co-location, and in terms of how that really encourages integrated working. And I think we've learned the hard way the challenge of digital integration. So we're literally just about to introduce the Plexus, which is the program which allows staff to access both sort of social care and health records. It's an interface sort of between different systems, but the information governance has taken a year to try and get the information governance sorted out. So hopefully some of the learning around the sort of pain around the information governance, we can then use that learning to make sure that other integrated communities don't spend a year trying to resolve information governance. So yeah, and then I think there's a real opportunity. I know we're already talking with other ICT footprints, especially along the coastal strip, where there are some similarities to Brighton and Hove in terms of population, that around how the learning from the Brighton Hove might be used within their emerging integrated community teams around people with multiple compound needs.
Yes, please.
So I just want to come back to Stephen. The Commissioned Aging Well Service has a lived experience advisory group who I'm sure would be more than willing to talk to you, which is quite a mixed group from across the city.
Can I just add another point? We also, within each of the 3 areas, the 3 sort of partnership delivery areas, have patient forums. Is that what we're calling that? Patient-led forums. So those patient-led forums feed into our community MDT discussions, and that person or persons from those forums also attend some of those MDT leadership discussions. So just trying to ensure that we are reflecting on the importance that the MCN program has had on people who are experiencing care being part of the change and delivery of care.
Any more questions, comments? All right, the report recommendations are: note the performance of our delivery of the 2024-25 shared delivery plan objectives. Approve the draft shared delivery plan objective for 2025-26. Does the board agree? I would like to invite Benedict Alves to introduce the report. Also presenting will be Agnes Munde, Head of Training Grassroots Suicide Prevention, Emma Sharp, Brighton and Hove School Mental Health Service, Brighton and Hove City Council, and James Atkinson, Deputy Director, Improvement of Effectiveness, Sussex Partnership Trust. Yes, report about suicide. Yeah.
Thank you, Chair. I'm going to pull up the slides. So hello to everyone. I'm Bernadette Albers, a consultant in public health at Brighton Hove City Council. And this item is about updating members on progress against the 3-year suicide prevention action plan. And as you said, it's a joint presentation, and I'm joined by 2 of my colleagues. I'd like them to introduce themselves. So Agnes.
Hi, I'm Agnes Monde. I'm the head of training at Grassroots Suicide Prevention.
Emma.
Hi, I'm Emma Sharp. I'm the acting service lead for the school's mental health service within the council.
And we were going to be joined by James from SPFT, the city's statutory mental health provider, but early this afternoon he sent his apologies. I'm just slightly struggling to present, so apologies for a moment. There, I think that's working. So suicide prevention takes place at both city and Sussex level. And this item describes progress not only against the city action plan, but against the Sussex suicide prevention action plan. So where there is similar need or where there are opportunities to maximise outcomes at a kind of pan-Sussex level, the system seeks to build on pan-Sussex initiatives and programmes, but where there are local opportunities or local need or particular circumstances to the city, the system seeks to build on the city initiatives and the city programmes and services. So in brief, what I'm going to talk about is the strategic context, the need in the city, outline progress at a fairly high level against the action plan, and then pass over to our partners who will talk a little bit more about their own work. So reducing deaths by suicide is a national, regional and local priority. Every death is a tragedy and is a cause of profound distress to family, friends and colleagues. And the impact of it can be very widespread. So it's estimated that up to 135 people can be affected by any one death. So the impact kind of spreads out from a single event. And in 2023, the city developed an action plan, and the same year, the Sussex level developed a Sussex strategy and associated action plan. And this 3-year suicide prevention action plan was brought to the Health and Wellbeing Board in November 2023 and signed off here. And at the same time, the Pan-Sussex strategy was brought here for noting. It's worth noting also that East and West Sussex have produced their own action frameworks, and all 4 documents, so the Brighton Hove, East Sussex, West Sussex, and the Pan-Sussex document, are all aligned against the national strategy. So many of you will be aware that the city's got very high need, and what this graph shows is suicide rates in Brighton Hove, East Sussex, West Sussex, and England. So England is the red line, which is fairly stable, and Brighton Hove is the dark blue line, which is at the very top. And what you can see is that over the 20 years that this graph shows, the rates in the city are very much higher than they are in England. And in fact, they are statistically significantly higher across all of those 20 years. Currently, our rates are 1.5 times the England average. We're like the 6th highest in the country. And for women, we've actually got the highest rate in the country. There's an average of 43 deaths per year. And obviously, there's a very, very much larger number of people who are affected and bereaved by each of those deaths. The reasons for our high rates are complex and partly explained that we have very high need in several areas. People with multiple compound needs, we've just heard about that. High levels of mental health, high levels of homelessness in the city, high levels of problematic drug and alcohol use. And some of the work of the action plan is actually around trying to understand more and explore some of the challenges of the city. And this includes a suicide audit of coroner's records. And we've also had some recent local surveys, such as the Health Count survey and the ongoing Safe and Well at School survey. And this also gives us quite rich data and a rich understanding as to what might be happening within the city. So the next graph shows hospital admissions as a result of self-harm. So many instances of self-harm will not result in hospital admission. So this graph is effectively showing a kind of tip of the iceberg. So an individual may not seek help, or even if they do, if they go to A&E, they may not need or be admitted to hospital. So this is not showing the completeness of it. We know that self-harm is much more common in young people and in particularly in young women, and hence this graph is showing the rates for those aged 10 to 24. You'll see that there's a bit of a downturn in the last 2 years, both nationally, East Sussex, West Sussex, and Brighton and Hove. There has been a methodological change in which the data, in the way in which this data has been captured, and there's some evidence that that might explain some of the change. We know that services report increasing complexity, so there may also be changes in help-seeking behaviour. People may be seeking support more from the community, or not being admitted, or not presenting to A&E, or not being admitted. We don't fully understand that last change. It may just be a kind of a data issue. But what we do know is that for each of those data points over the last 8 years, again, the city's got higher rates than it has for England. And in fact, it's the Sussex problem. East Sussex and West Sussex have also got statistically significantly higher rates. So it's a shared issue. So how does the city, or how is suicide prevention activity overseen and implemented? Well, as I kind of said earlier, it happens at both Sussex and at city level. So at the Sussex level, the Sussex Mental Health, LDA and Learning Disability and Autism Board oversees the Pan-Sussex strategy. There's also the Pan-Sussex Suicide Prevention Steering Group. At a city level, we have the Mental Health Oversight Board, which provides governance, and that's recently become both an adult and children-focused board. And we have the Suicide Prevention Steering Group, which is the group that leads the implementation of the action plan. And this is supported by the Partnership Group, which is a group that's open to 70 plus individuals, open to anybody who's interested in the city to join and discuss, share learning, share best practice, kind of communicate key messages. Sussex Partnership NHS Foundation Trust, SPFT, are also developing a suicide prevention action plan as part of their trust strategy, and this will be aligned with the Sussex strategy. I would say that kind of governance is strengthening. In October of last year, there was for the first time a Pan-Sussex Suicide Prevention Conference, which was really successful, over 200 attendees from over 60 different organisations. So there's really strong engagement right across the piece. In terms, so this last bit is really about, one of my last slides, is progress against city priorities. So within the papers, there are 2 appendices. One gives a detailed update against the city plan. The other gives an overview of activity at Pan-Sussex level. I'm going to, at the end of this slide, I'm going to be bringing to partners to talk about a few examples of some of the work that we're doing. But this slide is trying to give an overview of some of the priorities within the action plan. So in terms of responding to incidents of suspected suicide, a lot of this is focused around specialist suicide bereavement services. This is currently being recommissioned. NHS Sussex ICB have recently committed to funding the service ongoing across Sussex, and Public Health are working with the ICB on the recommissioning around evidence review, stakeholder interviews to really get a kind of coherent, shared approach that works, but is also tailored to the different places across Sussex. Next, expansion of the multi-agency mental health and education triage service, but Emma's going to talk about that, so I won't mention any more on that now. There's been some extended collaboration around DARDAs, the domestic abuse-related death reviews. This is an extension of the domestic homicide reviews, which have national guidance around extending those to consider people who have died by suicide but were victims of domestic abuse. There was also a workshop just a month ago, a Pan-Sussex workshop, looking at how we can strengthen our collaboration and joint working as we respond to incidents which we are notified by Sussex Police. Involving people with lived experience, we have a new Pan-Sussex Suicide Prevention Lived Experience group set up by our voluntary sector partners, grassroots and possibility people. There has been involvement of people with lived experience in the general practice training, which Agnes is going to talk about, some work around people with co-occurring conditions, mental health and drug and alcohol conditions, And this is something that we want to embed and do more as we kind of extend and develop the programme further. Suicide prevention training. Agnes is going to talk about suicide prevention training in general practice. There's also wider workforce training plans, including domestic abuse. We've already talked about the rationale for that. There's a suicide audit analysis of 3 years of coroner's records underway, and that will help us to understand more about the challenges and what's happening within the city that we can use to inform our plans going forward. And the final priorities around self-harm. We've recently ratified some new self-harm guidance for schools. There was self-harm guidance, but it's been pulled together, revised, and it's been signed off with SPFT. It's going to be kind of, working collaboratively, so we're all kind of saying the same thing. And there was a conference in November of last year. So I'm going to stop here and pass across to my partners. This was the first one, was going to be from SPFT. I'm not going to go through all the slides, but the kind of central one was around the focus this year was around ligature points, and also there's around embedding the governance structure around training and partnerships. I don't know, Colin may want to contribute at some point afterwards or later on. Agnes, over to you. I can do your slides for you.
Thank you, Bernadette. That's very kind. So it's a pleasure to be telling you about a very exciting piece of work that we've been doing, commissioned by Bernadette's team and the ICB, which aims to develop the skills and confidence and resources of staff in general practice. Why was this commissioned? Because of the fact that the majority of people who die by suicide are not open to mental health services, and many of them, the majority, will have seen their GPs in the year before taking their life. You would think that because GPs and, most of the staff in general practice see those people day in, day out, I've been told it's a daily part of my work, you would think that their confidence and reported confidence was high. However, there's a high level of anxiety about supporting suicidal patients, and the majority of people had never had any training, which is quite staggering. So we are aiming to address these issues and to enable anyone working in general practice to be able to identify and support effectively and with compassion people who present as very distressed. So the training program is open not just to doctors, but to clinicians and non-clinicians, because receptionists can have, as we all know, such an impact on whether someone feels heard and seen. Do you want to take the next slide, please, Bernadette? Thank you. So how are we doing this piece of work? Because, as you well know, doctors especially are incredibly busy. So we wanted to make the training as accessible as possible. So what we're offering is face-to-face or live online training. We've already trained some of the PCNs, and it's 2 to 3 hours live training with expert by experience input. So that's a part of the training. 16 e-learning modules that will be available whenever people want to access them. As well as at the moment we have 3 podcasts planned and hopefully a 4th in construction. Although the face-to-face sessions are only commissioned by Brighton and Hove, we wanted to make sure that the e-learning and podcasts would be available Sussex-wide. So this is what we're doing. Those modules, the training has been developed after extensive consultation. We had consultation across the board, not just from staff in general practice, but also with some of the main services, for example, drug and alcohol services and other VCSCs who are have provided their input. We've also extensively surveyed and interviews our expert by experience who have contributed their experience to ensure that the training is really relevant and address local needs. We might also develop accreditation for this. At the moment, it doesn't seem that it might make much difference, but if it makes any difference to people accessing the course, we will definitely accredit. But we wanted to make sure those modules were short, relevant, and really targeted in terms of learning outcomes so that everyone accesses them. And so that we affect a culture change from risk stratification to moving away from that to really therapeutic assessment and suicide safety planning, which is done in a collaborative and tailored way. Thank you. Let me know if you want any more details on this. I can talk for hours about this.
Thank you. Thank you very much. Shall we move on to Emma?
Thank you. So I'm Emma Sharp. I'm the Acting Service Lead for the Schools Mental Health Service. We're a division in Brighton and Hove City Council that goes into all schools across the city. Thanks, Bernadette. Go to the first one. So we are overseeing a MAMET meeting. So I know there was talk earlier about acronyms, but MAMET stands for Multi-Agency Mental Health in Education Triage. And so we implemented this as a pilot with 3 Brighton and Hove secondary schools, looking at working around those young people who, especially those who've attended A&E in relation to suicidal ideation or actions and high levels of self-harm risk. And we have recently extended this out to all secondary schools in the city. So any secondary school within the city is able to refer their young person into us if they have a concern. There's partners from our service within the council. We also have the local CAMS team. We have social care, police, school nursing, wellbeing service, but we also have partners from Transforming Care Service and the drug and alcohol service DASH. So it's a wide-ranging span of practitioners that are in the space. Schools are able to refer as and when they need to around a young person. It's a simple referral form with a summary of their needs, and we meet every Friday for an hour. We discuss up to 3 people within a week, and then we will review those young people as and when needed. And the ideal around the space is that we are discussing the concerns, we're discussing the needs, and we're making sure that all the steps that are needed for that young person are in place. All the services are aware, any referrals that need to be made are discussed and actioned, and we can reach out to the families as and when needed. The space sits within the school's mental health service, as we are embedded in all the schools in the city, and we're also covering lots of different levels of intervention. So we hold the counselling pilot that was agreed last year, and we also run the mental health support team from a few years ago that was a national government initiative. And so because we have a graduated approach to support, we're able to try and make sure we're getting the right support in as soon as possible, but also look at all the varying different elements that we could put in place for a young person. During the school term time, we do mostly receive our referrals from schools. However, during school holidays, we are opening our referrals up to any other agencies, for example, social workers or police, to refer straight into us. It's not open from that perspective all year round, because the ideal is that we have a school member of staff present for that conversation. They see the young people the most in most cases. So it's really helpful to have their perspective on the day-to-day presentation of that young person and also the needs that are in place. We do these conversations, with support and awareness from parents and carers, and often the young person, if it's appropriate, so they know we're having the conversation, so that if another agency or a partner needs to reach out to them, they aren't surprised, they aren't confused about where this is coming from. And we're in the process of reviewing an information leaflet to give out to parents, carers and young people to make sure that they understand which services are talking about their needs and what the outcomes of that might be. If you could just do the next slide as well, Bernadette, thank you. So this is looking at our last year's worth of data. So across the last year, we had 61 young people discussed. So these are our new referrals that were identified across the year, and the main presenting needs that we are tracking. We do also keep a track on emerging trends. So for example, this last quarter, we have had more referrals that mention trauma or bullying, and also we have had some around eating disorders as well. So there has been a shift, and we will start tracking the data based on what the referrals bring. Young people can obviously present with more than one area of need. So 52 of our 61 young people presented around suicidal ideation, 44 of them were around self-harm, and 9 around gender identity struggles. I've just done our data for the last quarter, and I know for our last quarter, 100% of our referrals are around suicidal ideation or plans or intent. So there is a shift in that direction. So we'll be looking at trends and linking those in with wider networks as well. That's it for my slides. It's a whistle-stop tour of what MAMA is, but I can absolutely answer any questions.
Thank you very much, Emma. There's a couple more slides from me. This is in terms of finishing off this presentation. This is just a little bit about the financial context. So there isn't there's funding across different parts of the system. There is not one central funding pot for suicide prevention. It's delivered through the ICB in terms of the suicide prevention support, through one-off pots of money, joint council ICB, elements of the Brighton Hove mental health support service. But where there isn't sufficient funding or where there are potential gaps, this is partly addressed through collaboration and partnership working across the organisations. This slide, I won't really kind of cover it in detail. It's just about some of the risks associated with the plan and insufficient prioritisation of resources. We know that it's a greater stress in those bereaved are themselves at higher risk of suicide. So that's kind of a really kind of key priority to keep the bereaved specialist services going. And obviously, the more that we can do around suicide prevention, it reduces pressure in other parts of the system. So that's essentially, I hope this paper or this kind of update has provided a summary of what we are doing in Sussex and at city level. It hasn't got into detail because there's such a lot within the appendices, but really open to questions.
Thank you for your reports. Any questions, comments, answers?
Thank you, Chair. Firstly, I want to acknowledge the amount of work that's gone into this, Bernadette and the team. I mean, under your leadership, if you actually read the full report, it's quite breathtaking, the amount of work. So well done, thank you for that. 2 questions really, and I actually also wanted to comment on the tragic numbers of our children and young people with suicide ideation. I think the fact that we've identified children and young people as a priority for next year is just highlights why that has to be one of the priorities. And our last Health and Wellbeing Board was focused on children's, young people's mental health and wellbeing. So, I mean, that's just cements why that's such a priority for us. My 2 queries were around, one was around the training, because it sounds to me as though it should be almost mandatory for anybody involved in face-to-face sort of engagement. And I was just wondering if you could tell us a bit more about the potential rollout for this. Will it go? I was thinking we've got our neighbourhood mental health teams being developed. We've got our integrated care teams. We've got hospital staff. I'm just wondering the extent of where we can go with this. And my other query was just around what we know about the touch points for people. And whether that will come from the coroner's review and maybe the league members. Because I think it's just so important for us to understand people's journeys before they get to the point at which they might best tragically take their own lives. It's such a tricky thing to gather information, but I think without that, we can't really identify how we can start to address those issues. So I just wondered if you could tell us a bit more about what the coroner's review and the league members might be able to tell us. Thank you.
Thank you very much. In terms of the training, I'll probably pass on to Agnes in a moment to talk about the general practice training and how that's going to be rolled out. In general, there is a time-limited pot of money, joint money, and so the sustainability is not something that we can't make it mandatory. It's got to be done through persuasion, through making the case to our partners around the importance of that, making the resources available to people. There are free resources on the internet. We're separately trying to develop a kind of database of training resources that other organisations might be able to use. Agnes, I don't know if you want to add anything about the rollout across general practice.
Yes, absolutely. This rollout, we have already started to run some of the face-to-face sessions for primary care network professionals. So it's their groups of surgeries, and we are aiming to have every surgery, accessing this course. We also run other training as part of a UK funding, so courses that are subsidized. So I really recommend people to remember that we have a wide range of subsidized or free training available, and that at Grassroots, we're always very keen to offer and develop other courses. So do feel free to approach us. We have a wide range of courses available. And we have lots of other resources. I just want to flag up our app, for example, our Stay Alive app, which is available in many languages, has been downloaded nearly 900,000 times and contain a huge amount of resources, both for people who are distressed and thinking about suicide, but also for people who are helping them. So I really recommend this app, and local authorities who have done campaigns about the app have seen their suicide rates decrease quite noticeably. So it's a free resource available in many different types. There's an app, there is browser version, there are PDF versions. I really recommend that you avail yourself of this. It's a free resource, and please talk to your colleagues and patients about this.
Thank you. Just on the second point around touch points, I think that's a really, really good kind of challenge. And we know that suicide is often kind of the end of an accumulation of a whole series of life events, and this can be around relationship breakdown or housing or debt or employment, etc. So this is around suicide prevention being everybody's business, and there's no straight answer to that question, but it's absolutely got to be part. It's a sort of strand of a large number of different services and support agencies.
Thank you very much. So, it was great to see all the work being done. I think the current medical model that we have, it tends to focus on the symptoms of problems and categorizes the symptoms and then works together to try and reduce the symptoms. And I think I sort of have concerns that's not really working. The more things we do, more medications we prescribe, the more therapy we give or talking therapy to try and reduce the symptoms, the rates of mental illness are going up and suicide hasn't changed for a long time. So really it's to you and the board, what as a city do we think we can do to understand the causes of mental illness, causes of suicide, and what can we do to try and work together to reduce the causes, which ultimately is the aim of the game. Because just reducing the symptoms doesn't work, or it hasn't been working.
Yes. Yes, please.
Thank you, Chair. I'm Tom Lambert. I'm one of two voluntary sector reps here this evening, along with Caroline. I guess following on from Adam's point, we've had some contact prior to tonight's meeting with some sector colleagues who work in the field around violence against women and girls. And so as one area of expertise there in the city, we note that in the presentation, Bernadette, you highlighted the high numbers of suspected suicides amongst women in Brighton and Hove. And also at a national level, we know that suspected suicides as a result of domestic abuse are now higher than associated homicides. And so bearing those two things in mind, how might our sector colleagues engage with programmes like the domestic abuse related death reviews that you cited earlier?
Just to kind of come in on both of those, I mean, they're really good. Adam's point is a really good one. I don't have a straight answer to that because it is all about prevention. How can we move upstream and try and manage some of the really difficult circumstances that people find themselves in, apart from and move away from treating symptoms. I completely support that. In the particular points around domestic abuse, the elements of this time-limited training budget is around how can we support workers in working in domestic abuse to do that suicide prevention training, ensure that they have the kind of skills and competence. That's something we're exploring. In terms of that wider strategic work around working with the domestic abuse related death abuse, there's a Pan-Sussex discussions ongoing about what that would look like. And it may be that there are other colleagues in the council who are also thinking about this, and we're kind of working with them. So there isn't a straight answer on that. It's a work in progress.
Thank you, Chair. I think it's great that we're, got this work in progress, and you're having the GP training, especially. We are in a mental health crisis. There is no denying it. In this year alone, have had to support 2 people to try and get emergency mental health. If we are trying to prevent, when you said that there's like a mismatch in the data, and we're touching the tip of the iceberg because people are perhaps going to the community for support, or they're presenting at the hospital and they're not getting admitted, there is an apathy now when you're supporting somebody in a mental health crisis. What do you actually do? Who do you call? So, for example, not this Saturday, the Saturday before, it took me an hour, and I did eventually get through to MERS, and I was absolutely overjoyed because an hour was good. I've spent 4 hours before and still not got through, so I thought, great, that's brilliant. I've been supporting people who've presented and been sent away from A&E. I just think until we tackle the fact that people will present and they will get turned away and they won't know what to do, until we're presenting a service where we don't have huge, massive waiting lists, we know you get admitted, and if you're lucky enough to get admitted, you end up in that ward with the airless windows, which I think we mentioned last time. I mean, what is the average wait time to actually get admitted in a mental health bed in Sussex? And the general public have just now got it embedded in them that they are sort of alone, because it doesn't matter how much you're struggling and you reach out for help. Perhaps when you're looking for prevention to deteriorate any further, you reach a brick wall and you're then just left with this apathy of, I have got nowhere to go and nowhere to turn to. So I'm very lucky in that the people that I was supporting could turn to me. Had they not had me, we might not have even got to the point where they would have been able to hang on the line long enough to keep ringing back MERS. So that's what we need to do. We need to change what we're delivering and making sure that we've got more beds and that we don't have waiting queues. And the GP training, I think, is brilliant. I'm really pleased about that. And the other thing, I'm very glad as well that, we're able to do Mehmet. I think that's amazing to be able to be in the schools talking to our young people. But these are very much needed and very welcomed. Anything that gets us out of this awful position that we find ourselves in. Thank you.
Thank you. And yeah, Bernadette, I think you're probably not surprised I'm going to talk about Stopover, which is supported housing for young women, but I think applies to all the other supported housing for young people, where if I give an example from a couple of weeks ago, which was extreme but certainly not isolated, where a young woman who lives at Stopover was actively suicidal, had taken an overdose, severely self-harmed on top of previous self-harm, and we'd called out an ambulance who considered she had capacity. She didn't want to go to hospital, so they couldn't take her. And our team, who have done suicide prevention training, are really skilled, but they're not mental health specialists. And it was incredibly difficult to get any external support for this young woman. CAMS told us they only had one clinician on that day, and she was in training. We did hear back from her eventually, and yeah, after making several phone calls, we did get to quite a senior level where something was put in place. But as I say, that there just seems to be this gap where young people, and I assume probably adults as well, they're in the supported housing and there's a certain amount we can do, but then there's just this gap where it feels like we're left. We know what's going to happen. This young woman had absolutely no desire to be in this world whatsoever. And again, on a Friday afternoon, we were just stuck trying to manage that situation. And I know, Bernadette, you've been in touch with the team there, and they're involved in the action planning, which is really good and a positive move. I think on the other extreme, several organisations are commissioned to work within the schools, delivering one-to-one and small group work with children and young people who are referred via the school nurses. That's a service that we've been delivering year on year. That's meant to be that early intervention and preventative. We've still not had confirmation for the contract for the year that we're already in, or we've been told, yes, there is a contract, but they can't confirm the amount yet. And so, again, we're carrying that and continuing to do that work without the external backup. I don't know if there's anything to add to that, but it's just that gap really concerns me.
Thank you, Chair. I suppose by way of trying to offer some positive impacts around some of this work, I think there's a couple of things to acknowledge. I think as a city, we are a young city. We only have about a fifth of the population age 16 above. So this is a challenge that's with us for a long time, and I think we need to think in a systemic way about how we address some of our suicide issues in the city. I think also suicide is particularly complex as well, because there are lots of causes that are socioeconomic that drive suicide. They're not medical, they're not people with pre-existing mental health conditions. But I think one of the common areas around suicide prevention is around that early engagement. And I do think the fact that we are looking to bring, at the moment, we have our primary care services here, and we have our specialist mental health services over here that you access through primary care. And that creates delays and that creates handoffs. And I do think the way we're trying to align our neighbourhood health in terms of our integrated community teams and our neighbourhood mental health teams being within the same neighbourhoods and same locality, that's got to be helpful in being able to reach out to those people that wouldn't normally contact services. So by way of example, some of the work that's happened in our local spaces, particularly around our kind of primary care networks and in lots of our health forums, work's being driven by our voluntary sector partners around improving access to health services for people that don't traditionally access those health services. And we're running some Healthy Mind community events. So I think one of the solutions that's structural has got to be how we more closely align our mental health services from the trust in primary care, and how we engage our voluntary sector in doing that early intervention work. Because I think people knowing they can go somewhere that's maybe non-threatening and non-clinical to talk about some of their issues has got to be a way of improving things. And it's that prevention work upstream that we've got to focus on. As Stephen's referred earlier, we're all challenged financially across the NHS and across the council. So I think aligning our services in the best way has got to be a more positive approach to addressing some of these problems.
Hi, just to say I'm Colin Hicks, I'm the representative here from Sussex Partnership Trust. First of all, I just want to acknowledge, I think it shows our progress, the fact that we're having this conversation without the focus being exclusively towards one partner organisation, i.e. what is the Mental Health Trust doing to do? So it feels like that is an incredibly important step, that we're owning it as a community rather than seeing it just within the kind of the realms of mental health. apologies that James wasn't able to be here for part of the presentation. Just a couple of points I just wanted to kind of sort of give. So one of the things that we've done very recently as an organisation is we just signed off on new trust strategy for the next 5 years. And the number one priority that we have is to commit to not having any suicides in our inpatient unit and to contribute to a 20% reduction in the rate of community suicides in Sussex. So fairly big ambitions for us organisationally. And note, we're talking about a reduction in community suicides. We're not just talking about suicide rates in our services, because we recognise that as a major agency employer within the city, we have a community kind of responsibility as well. There are a number of kind of more tactical steps that we're also taking linked into the suicide prevention plan. So some of that is around looking at embedding some of the recommendations from the confidential inquiry into sort of suicides, particularly around making sure that we try to prevent people being supported out of area. To do that, we've got an additional 15 acute adult beds coming online in the Brighton footprint over the course of sort of the next year. And there's a lot of work going on between ourselves, NHS England, and NHS Sussex, looking at really strengthening the kind of the crisis support provision to children and young people, because I think we recognise that historically it has lagged behind quite a lot of developments in adults as well. So I think there's a real commitment from the organisation, but from sort of the health system particularly, to really kind of continue to try and tackle what is a really challenging problem. Thank you.
Yeah. All right, please.
So I just really want to support what Steve was saying in terms of working together. This is one area I think we are working well together as a system. This is a really, really serious issue. I don't think any one organisation can solve this on our own. And I think integrated community teams is one of the ways forward, because the reality is there is no more public money available for this. We have to make better use of the money that we have. And I think actually one of the things I'd like to think about is how can we join together the economic agenda, the housing agenda, the mental health agenda, as well as then the support that we provided through integrated community teams, because that is ultimately the solution. We've got no more money, so therefore working in partnership, integrated community teams are one of the delivery vehicles towards that. There's no question of that. But I think it's actually beyond just the healthcare component. And I think actually how we link together, particularly housing and education and employment, feel like other contributory factors.
Any more questions, comments? No? All right. Maybe just an addition. I mean, from what we have heard, it seems that access to mental health services is a problem from the report and from the lived experiences which has been, mentioned from members. So I just wonder where in your priorities is that, is trying to make access, possible. And there's some mention about working with primary care, but sometimes you get these cases coming out of hours, going to hospital, and usually those are the cases who are, because I have a living experience of a case who was out of hours, went to the A&E, and was told to go back home. And this person was living alone and taking his own medication. So the next day he was found in his garden, gone, having taken overdose. So, I mean, there has to be a way whereby somebody who has an intention isn't alone, either admission or not left alone. That's the principle. How can you ensure that that is a priority? Thank you.
Just to emphasise, this is a partnership plan. So there's a whole set of components that are being led by people around this, sitting around this board and wider. So we've already heard about the community mental health transformation programme is one of the kind of areas within the plan. And it really focuses on the neighbourhood mental health teams, which Steve Hook has already talked through. And it's about the integration, pulling together different services, primary care, voluntary sector, and secondary mental health services around individuals so that they can get the best support possible. There's another element in that, which is around the work around transforming crisis care. That's being led at, I think, by ICS. I think it's ICX are leading that work, but it's in there. There are kind of key transformation programs within the wider community mental health program.
Any more questions? The report recommendations are: notes progress against 3-year Brighton and Hove Suicide Prevention Action Plan 2024-2027. Supports future progress of the Brighton and Hove Suicide Prevention Action Plan. Does the board agree? So the last item is Better Care Fund. I would like to invite Charles Walker to present the report.
Everybody. So part of my role is I support our health and care partnership in administrating the Better Care Fund. So the report's been put together as a partnership, and so I'll present the report, but questions will be supported by Steve and Tanya as our SROs of our health and care partnership. So just bear with me, I've got a few slides just to help take us through the key points from the report. So just as an introduction, the report that was in your pack, it covered our BCF planning submission for 25-26. Agreeing this submission is a key responsibility of the Health and Wellbeing Board. So the report covered some of the key details around the national planning framework for the Better Care Fund, particularly looking at the national BCF objectives, which changed this year, and the conditions of the grant. The report covered a summary of the BCF narrative plan that was submitted, and a summary of our expenditure plan, our planned national BCF targets, and our capacity and demand modelling, which all go up to make the plan. And we'll be asking the board at the end of this presentation to approve the submission. So just quickly, in terms of the national objectives, they are slightly different this year from previous years. They're very much focused around the new government's reform agenda around the NHS and what's being sort of consulted on within the NHS long-term plan. So the first objective of the Better Care Fund is to reform to support the shift from sickness to prevention. So in agreeing a plan, we must agree a plan that helps people remain independent for longer, prevents escalation of health and care needs. So the second national objective is to reform to support people living independently in the shift from hospital to home. So again, plans need to cover how we'll help prevent avoidable hospital admissions, how we'll achieve more timely and effective discharge from our acute community mental health hospital settings, and how we can reduce the proportion of people who need long-term residential or nursing care. Just in terms of the national conditions that we need to meet, so the plan needs to be jointly agreed. So that the plan needs to ensure we're implementing the objectives that are just set out, and that we comply with the grant and funding conditions, including the maintaining the NHS minimum contribution to adult social care, and we are complying with the oversight and support processes. So just in terms of the narrative plan, which is part of our draft submission, so the full narrative plan was appended to the report in your pack. So just summarising the narrative plan drew from the Sussex ICT Neighbourhood Health Plan, which is a system plan agreed by system partners. It also drew from our system and place discharge planning and from our local health and care partnership, joint strategic needs assessments, and our health and wellbeing strategy. Plan set out the ambition that we have in Sussex for integrated community teams, which has been a big part of our conversation in our other agenda items, and how this fits with the new national BCF reform objectives, and how this is then reflected in the individual scheme investment profile as part of our plan. Plan set out the learning from our hospital discharge transformation programmes, including the review last year of Professor John Bolton, and how this again is reflected in the investments that we've made in the BCF plan. Plan set out a rationale for our plan performance against the national metrics, set out a methodology for our capacity modelling, and the plan reflects our local health and care partnership priorities. That's just a quick summary of the narrative plan. Then in terms of the expenditure plan that we've drafted, so just to confirm, the expenditure plan meets all the national conditions. So our grant value for this year is just over £43 million. That's invested across 72 individual schemes. Roughly 27 million of that investment is in community focused services and 16 million within hospital discharge. Important when we're thinking about those community services, a lot of those community services are focused on preventing avoidable admissions. So within the sort of breakdown of the expenditure, the local authority Better Care Fund supports both community and discharge investment that's delivered directly by the local authority, but through an agreed plan. NHS minimum contribution delivers the required minimum spend on social care, and again supports the agreed partnership priorities of the plan. And then just the additional local authority investment covers additional investment in carers and community equipment. So in terms of the metrics, we're required to set out our performance, our planned performance against 3 national metrics. The first one is around emergency admissions to hospital for people aged over 65. This covers unplanned hospital admissions for chronic ambulatory care, sensitive conditions, and emergency hospital admissions due to falls in people aged over 65. So the target we set is 507,000 per 100,000, noting that we provide it on a monthly basis with some seasonal variations. So the second metric is the average number of days from discharge ready date to discharge. So target we set is an average of 1.51 days in terms of discharge delay. That's based on 87% of people being discharged on time, and those not discharged on time an average 12.7 days delay. Then the final one is admissions to long-term residential and nursing care, people aged over 65 per 100,000, and the target we set is 253 per 100,000 of the population. So when setting these targets, we looked a lot at last year's performance, recognising the sort of real pressures in all of our systems and the current significant resource constraints. So really targets have been set pretty much where we are currently performing, are seen as important to try and maintain current performance within a very constrained and difficult environment. So just the capacity and demand modelling. So this is supported by NHS Sussex through the business intelligence teams across both the Integrated Care Board and our trust partners. Demand modelling is based on experience of previous years. It's based on a step up, a step down, and a step up. So step down is capacity within certain discharge pathways, and from hospital into the community, and step up is modelling our sort of urgent care, community, hospital prevention sort of pathways. So again, they're very specific pathways. We're modelling demand within our sort of step up of 2,020 people that will use those pathways with a small surplus capacity in our system there. And then we're modelling in the step down capacity of 534 people per month using those systems, so those pathways. So in our narrative plan, we did highlight that this is very complicated work in terms of actually modelling and bringing together a range of different partner systems. So there's still further development work that we'll want to do over the year to continue to improve our capacity and demand modelling. So just in summary, we're asking the Health and Wellbeing Board to approve our planning submission. For assurance, the plan has been developed through our Better Care Fund steering group, which has all partners on it, and it's been through our Health and Care Partnership Executive Board. Plan has been signed off by both ICB and local authority chief execs and finance directors. Plan's been presented and supported by the chair of our Health and Wellbeing Board, and the plan was submitted to NHS England in draft form on the 31st of March as per the requirements of the planning framework. We will expect NHS England to confirm by May the plan, and then we have till the end of September to draw up the Section 75 agreement, which is a legal requirement where we're pooling budgets between local authority and NHS. So we will need to refresh the current Section 75 agreement by the end of September. So that's a quick summary of the plan.
Any questions, comments? Explain.
Thank you, Chair. Thank you, Chaz, for the presentation. As always, we appreciate your support and acknowledgement of the expertise and skills that the voluntary sector brings to better care funded projects. Perhaps you've answered my question just at the end there with the Section 75 reporting required late September you're expecting. Am I right in thinking that process is what decides the expenditure plan that's outlined in the public pack? And in addition to that, in light of Stephen's comments earlier about the challenges that are being faced at an ICB level, I recognise that in February I asked a question on a Better Care Fund item about how we as a sector should engage with the process. And of course, you answered rightly around the SVLA as being the vehicle that we should engage with. But I guess my question is that in light of the uncertainty around ICB funded initiatives like that, if SVLA was to be affected, for example, how would statutory partners ensure that the voluntary sector is represented in discussions in future steering group decisions?
Thanks, Tom, for the question. So in terms of the Section 75 agreement, that's very much a technical thing that allows pool budgets between the NHS and local authority. So what you'll be agreeing today is the expenditure plan that we'll be operating to from the beginning of this month. So in terms of consultation involvement of community monitoring sector, so firstly, and I think this was set out in the report, there were no further cuts in the BCF to voluntary sector partners. So, and there's really important work done through things like Ageing Well, through the Carers Hub, through the sort of Red Cross services in our hospitals. So that we recognise the really important role that the voluntary sector plays in delivering our BCF plan. So there was no further cuts to previous investments that we've made into the voluntary sector. Obviously, as Stephen said, there's a lot we've got to work out about what the changes to funding of ICB will mean. That doesn't change the fact that the BCF is a partnership plan. So one of the formal partners is the community and voluntary sector. So if the SVLA for any reason wasn't able to be part of our steering group, we would then need to look at how we achieved representation in another way to make sure, because we have to confirm that this is an agreed plan across all partners within the Health and Care Partnership. So.
Thank you. And if I might add to that as well, Tom, is part of the SVLA's role is to seek membership from across the voluntary sector. So as Chaz said, there are a lot of programs that feed into the BCF that are part of that membership seeking through the voluntary care organisations, the discharge transformation programme as well. A lot of the discharge programmes are funded through the Better Care Fund. So we would have volunteer members from the BCC sector who are part of those discussions. But I also just wanted to flag that the point that Chaz raised earlier is that a lot of the schemes, although there might not be a significant reduction to
the schemes, particularly that we commission through the voluntary sector. What we'll be looking at is working with the voluntary sector to ensure that we're seeing the value for money, that you feel supported with the services around those core commission services. Because what sometimes we hear is that there's a block then of the support you can offer and feeding into the statutory bodies around, particularly for those clients supported. So what we want to do, and Steve and Stephen mentioned that earlier, is the reorienting of bringing services together. So a lot of our conversations with our local authority partners, how can we joint commission? What are the areas and the opportunities for joint commissioning? And after the Section 75 conversation and agreement, we'll be looking at teasing that out and making those more robustly possible over this year. Because, there is no more money, and we do have to make what we have work further, faster, and more efficiently.
Yes.
Thank you, Tanya. Thank you, Chair. I guess I wanted to make the point that there was a sort of a purposefulness of bringing the BCF here today alongside the fact that it needs signing off. But I hope board members have been able to see today that we talked about our shared delivery plan objectives, which were about moving from sickness to prevention, about looking at integrated community teams, around focusing at prevention from hospital admission. And I think what we've tried to do really purposefully for this year, and the steering group have worked really hard at it, is we've tried to align our Better Care Fund spending to those priorities. So there's a kind of a thread that goes through. So as Chaz has said, notwithstanding we're in a very difficult financial position, we've made a commitment not to reduce investment in the voluntary sector through the Better Care Fund. One of the significant things we've done as well is that we're committing just over £1 million worth of investment around homeless healthcare in the city, which links in with our multiple compound needs programme. And I think unlike 24-25, when we had quite a challenge to deal with our kind of winter hospital discharge, because we didn't get the money just before December, we've agreed a £16 million Better Care Fund investment into our wide hospital discharge work. And now that means we can start planning for winter pressures in June, July, because it takes 3 or 4 months to recruit additional staff, rather than trying to plan for that work in December. So I guess we're hoping the board can see that sort of thread from what our priorities are, given that we have limited resources, and how we've tried to invest our joint fund into those right priorities. So I think, notwithstanding the difficult financial position we're in, we think that our first round of planning for the BCF for 2025-26 really aligns with our priorities, which is why we're quite confident that we'll be able to spend that money in the best way possible over the next year. Thanks.
Yeah, thank you, Steve. And I think certainly from my perspective, I think we can approve this plan with confidence because actually the rearrangements of the NHS infrastructure does not affect the service delivery of this particular set of funding. So I think we can therefore go ahead and approve this, is my view. Just in terms of the measures, I do just wonder whether we've tracked through. So, for example, on the £16 million worth of discharge funding, I'm wondering whether that's actually been calculated at how many reductions we're going to have in people with no criteria to reside in our Royal Sussex County Hospital. So have we gone to that level of detail yet, or is that still to come? Will be a question.
Thank you, Stephen. I thought you'd ask about that. I think in terms of the investment, as Chaz has said in his presentation, we've based a lot of our work on the work of Professor John Bolton. It's been a very challenging winter around sort of discharges, but I guess just in terms of some of the hard numbers, across Sussex, each place has a discharge transformation group, and we are just kind of agreeing the metrics and the optics for each place. We've moved from looking at a Sussex-wide set of measures around people that are delayed into a place-based approach. And in Brighton, that's particularly at the county hospital. So, I can give you, in terms of the information for people who need adult social care support that are delayed. In January at the county hospital, we had 22 delays at the end of January, and that's now reduced down to 11. And around our mental health delays, in January we had 26 patients delayed in mental health hospitals. That's reduced now down to 16. So there is some measurable improvement of how that investment in the last 3 or 4 months has actually resulted in some improvement in performance.
And can I just ask, have we started to model what the impact of the Better Care Fund for 25-26 will be on those numbers at the end of March 26?
Yeah, so the improvements in performances as a result of that BCF investment. So we're extrapolating the continuation of that over the coming year.
Any more questions? All right. The recommendation is to approve our Better Care Fund submission, planning submission for 2025-2026 to NHS England. Does the board agree? Okay. I declare the meeting closed. That was the last item.